This panel is entitled Health IT and Select Populations. This panel will be moderated by Pamela Jeffries of Johns Hopkins University. Dr. Jeffries is Vice Provost for Digital Initiatives at Johns Hopkins and Professor at the School of Nursing. She is nationally known for her research and work in developing simulations and online teaching and learning. By the way, simulations are very dear to my heart. Dr. Jeffries served on the planning committee for this workshop and is a member of the Institute of Medicine's Global Forum on Innovation in Health Professional Education. Dr. Jeffries.
Thank you very much. Well, as with previous panels, I'm going to introduce the speakers to my right, and I hope you find this as an informative and fun panel because we're going to talk about exemplars of health IT throughout this session for the next hour and 15 minutes. Our first speaker will be Katherine Kim. She's from the University of California, Davis. Dr. Kim's an assistant professor at the School of Nursing at the Betty Irene Moore School of Nursing at UC Davis. Her research focuses on information technology to improve community health, care coordination, and clinical research. She's led many research projects using participatory methods to design, implement, and evaluate mobile and social technology-enabled health interventions and distributed research networks. Her current work includes areas on cancer, obesity, heart disease, and other chronic conditions. And then she also said just 2 minutes ago, she said, oh, by the way, I also have had a technology startup, so I come from the product perspective too. So she's got a lot of hats that she's worn. Second speaker is a colleague of mine from Johns Hopkins, but now has left and is in Florida. She's an associate professor of nursing in the College of Nursing at University of Southern Florida. Her research interests include advancing the care for childbearing women and newborns, using existing clinical and financial data to examine prenatal care, health service delivery, and outcomes, and evaluating mobile technology that educates pregnant women and new mothers. And I was very close to her work and followed it closely through the Text for Babies that you'll hear more about. And our third speaker, Winston Wong. He's a member of the IOM Roundtable on Health Equity and the Elimination of Health Disparities. He also serves as the medical director and community benefit for Kaiser Permanente. He directs Kaiser Permanente's investments and partnerships to support the nation's safety net and to improve population health in vulnerable communities. So without further delay, Dr. Kim.
Thank you very much. It's my pleasure to be here. It's not in my slides, but the message that I'd like you to take away is that there are types and there are stereotypes. We tend to build technology to the stereotypes. So I want to illustrate that first by introducing myself. What you probably see in front of you is a middle-aged Asian woman, fairly educated because you just heard my biology, have some technology experience. But what you don't know about me that I just learned about myself is that I'm 3.4% Neanderthal. When I learned that, it had a huge impact on my perception of my health. I somehow felt more vigorous, more robust, like I could take on anything. And that's important because I had gestational diabetes with my second child. I have been told that I am at increased risk for developing diabetes, that I should lose some weight, which is, the majority of Americans probably think they should lose some weight. But it clearly is not important enough for me to actually do because I think there's a statute of limitations on using the baby weight as the excuse. My daughter's now 19. So I think I've reached that statute of limitations. So it's clearly not important enough for me to actually do something about it. But the other thing that you should know about me is that there's one thing that I do about related to my health very actively and very regularly every single day, whether I'm at home or whether I'm traveling, and that is brush my teeth. So there's one point at which you always know I'm going to do something about my health. So my challenge to you, and maybe we can get ONC to pay for this, is to build an app that causes me to lose weight knowing what you know about me. Okay. So there was a type, and there's a stereotype. Had you built from my stereotype, you would have said, doesn't care so much about weight, is not that concerned about diabetes, because Koreans are not in the group of Asians that are prone to diabetes. Probably uses lots of health apps because she's in this field. I have no health apps on my phone. So you would have built something for someone like me assuming something. Knowing something about me, though, you might now build something different. So I'm here to talk about partnerships with Native American communities, because you now know I am not Native American, but I work with community. And there's three things that I want to talk about. One is structural health disparities and the digital divide in the Native American community, the landscape of health technology efforts going on currently, and then opportunities for research and development. So first, there are 3.7 million American, Indian, and Alaska Native people in the United States. The Indian Health Service is the primary provider of care for them, but they only serve 2.2 million. Most of the people that they serve live on reservations, and we know from this number now that most of the, a large group of the Native American community does not live on a reservation, and therefore is not being served in a tribal clinic. Life expectancy is quite a bit less than the rest of the American population, 4.2 years less across all Native American groups. And all-cause mortality is 1.2 times higher. So we're not going to go into detail about what those disparities are, but there are significant health disparities among Native American people. There's also a great digital divide. When you think about healthcare applications, healthcare technologies, really access to those things when you are making a decision, when you're making decisions about what to do, what information to look at, you really need it in a private place that's accessible to you when you're making that decision. And so for most people, that's having home internet. We know that 96% of the richest people in the United States have home internet, and only 25% of the poorest. So when we say we're getting adoption, we're gaining connectivity for those who are in underserved communities, it is still a vast differential between who has access and who doesn't. For home broadband, which is really critical for most health information technologies. And here we have a great divide for the Native American community as well. So the group with the largest percentage of home broadband is Asian Americans, so 69%, whereas only 30% of Native Americans actually have access to broadband in their homes. So when you have broadband, you do different things. When you have broadband, you can use sites that have rich and dynamic content. You can look at news. You can search for jobs and submit applications for jobs. You can look at blogs. You can post blogs. You can publish your own information. Those are things that you don't do if you don't have broadband. In our schools, we have the same situation, and this is across all ethnic groups now, not just around Native Americans. But for those in minority schools, they have 37% more users per internet-connected computer. So students in minority schools are waiting longer to use the computers that they do have access to. So in this context, Native American technology efforts have really focused on some of these infrastructural issues. So access to broadband and access to public places where there's internet-connected computers. And for the Native American community, that's primarily tribal centers and public libraries. So these are just a couple of those efforts. The Gates Foundation program that really invested in bringing technology packages to Native communities around reservations, as well as rural communities that are not reservations. So they've done things like bring packages of broadband connectivity, hardware, software, training, education, so that those things could actually be implemented in those communities. There's also the Federal Broadband Technology Opportunity Program, which is money that goes, some of those funds are going towards getting rural communities connected. A portion of that money has been focused on Native American communities as well, to bring broadband into the community, but not necessarily to address the last mile issue, which is getting from broadband to the home. That's still a real critical gap. Public and tribal libraries have really provided some critical access, primarily around access to published information, access for educational purposes, things like that. And the National Library of Medicine has actually, for a number of years, had a Native American outreach program, really targeting the production of content that's important to Native American communities, as well as getting access to that information for tribal communities. So there are a number of efforts dealing with the infrastructural issues. Now, once you have infrastructure, then you can actually think about how can we use that infrastructure for health. So there was a systematic review done about 3 years ago looking for research that had been done around technology use and health disparities. That review found a total of 4 papers that even mentioned Native Americans. This was not my review, this was somebody else's review. This is Sanguine's review. And so we updated that and looked again in the last few years and say, what else could we found? I think we found 2 additional papers. So this is an area that really has not come out in the published literature. There may be things going on in the community, they're just not in academic publications. But the work that's been done has been primarily around online education, because the access to K-12 education for tribal communities is still quite limited. And so there's been a lot of work around how do we improve the K-12 education and early adult education, since K-12 has not had the resources that it needed. There's quite a bit of work from the Indian Health Service around telemedicine, and I know that's not consumer-facing necessarily, but it is clinic-facing, where consumers are getting access to specialty consults and things like that that hadn't been available to tribal clinics in the past. And they've had some very good results in terms of wait times for specialty consults and access to specialists that were not available at all prior to telemedicine. The 2 examples here, the My Preventive Care PHR, you already heard about from Alex Christ and his wonderful work. We were very pleased when we saw the preliminary protocol paper on that, because 2 of the practice-based research networks there have a significant number of Native Americans represented in their network, one being Ochin and the other one is the New Mexico group. The New Mexico group actually has 8% of their population is Native American. So we're very excited to see what the findings are around disparities and uptake of the patient portals among those populations. The last one I'll talk about is mobile health for youth. There's been great interest about STDs, about teen pregnancy, and some of these other issues in the Native American community, and there's some work in the Pacific Northwest that's been an extensive community-based process to identify the topics and the venues for providing engagement to youth around these issues. So there is some work going on here. But obviously it's not as much as there needs to be, given the importance of this population. And I would say that there's a couple of opportunities that we have in this room and in working with communities that we should consider. And those opportunities are around culturally grounded evidence and culturally grounded technology enablement. And I'm going to use my work as an example for these. So first is culturally grounded evidence. And so this is a wordle that what I did was took the words that represented Native American traditional values from Coyhis and Simonelli's work and put that into a wordle. And you see words that we don't tend to actually use when describing our sorts of health information technology research: patience, balance, humility, spiritual, respect, sovereignty, restitution, autonomy, calmness, plurality. And it's important that these traditional values actually come throughout the entire continuum of research and development in order for us to really engage the Native American community in improving community health. The National Congress on American Indians, they actually developed a research agenda in 2007, and you can see addiction and diabetes are 2 of the health issues that they're primarily interested in, but there are others. And they developed a tribal research curriculum which was intended to help tribal members to engage in research successfully. So this is our example. We have a project that's funded by the USDA, and it's actually a regional strategy to improve food security in the Klamath Basin, which is an area in Northern California, Southern Oregon. So we're working with 3 tribes, the Karuk, the Hupa, and the Klamath tribes. Our initiative is engaging youth with mobile technology so that they become drivers of community health. So one of the things that we did was actually develop a research curriculum, which was engaging the youth to become community researchers, and we taught that over several months. Then they used mobile technology to actually conduct the research and engaged in this project. These are 4 members of our youth research team who developed this project. And the results of it were actually were presented at our Clinical Translational Sciences Center at UC Davis. So they presented to a packed room of physicians, nurses, researchers, community members, and they did an incredible job. I'm going to share just a very brief part of that presentation with you, and I should say that I'm approved to do that because we agreed that they would be the first to present their work since it is their research. And I'm and the other members of the research team are actually only allowed to present once they've approved the content. So this is approved content. So they did a survey which was a community food and health assessment. They were engaged in looking at 4 different methodologies: survey, interview, graffiti wall, and photo voice. These were methods that they felt were sort of culturally appropriate because they're concerned about storytelling, they're concerned about observation, they're concerned about community engagement of members within the tribe. And so they looked at these sort of methodologies. They actually ended up determining that they would use a survey, but done verbally, because there's very little connectivity in this region. So most people don't have access to technology, so you can't put a survey monkey up there and expect that people are going to respond to it. So they developed the survey. They actually used Magpie software, so they could have the survey instrument on their iPods in a disconnected mode, collect the data as they were interviewing people, and then upload when they got to the tribal computer center. So this is one of their results. So 212 individuals. The question they were looking at is confidence around healthy food choices related to physical activity or not? And what they found was, in fact, this is very related. So they decided that they were going to do something around physical activity because that had an impact on confidence about food. The second method they chose was photo, not photo voice. The picture on the left is a stack they were given at school on test day. The picture on the right is the traditional Karuk way of smoking salmon that's caught in the salmon river there. Here's a clear difference in what we do today versus our traditional relationship to food. So that's an example of the youth being community researchers, addressing a community concern, and then wanting to do something around it. What they wanted to do around it was to have an intervention that encouraged people to do physical activity. So interestingly, we thought, well, we'll make a game out of it. They can compete on the game and all that kind of thing. And they said, no, we don't compete with each other. We collaborate with each other. And it's really important that we engage the wisdom of the elders along with the youth. That's what we want to do. So they actually came up with an idea around, it is a game, but it's called Walkabout, which is a mapped walk that takes you through the community, through the countryside, allows you to look at native plants, understand what significance it had for the tribe, how to prepare it, where to gather it. But here's where community engagement is really important, because the data that you collect when you have a game like that is GPS locations. And some of those locations, the walks they were going to take, go to tribal sacred sites and important cultural sites, which are not allowed to be shared outside the tribe. In one instance, they actually had GPS locations of mushrooms. Some people found out where these mushrooms were and came in and wiped them out and took them to a farmer's market and sold them. So these are the kinds of things that the tribe is concerned about in terms of sovereignty and protection of resources. This is the last picture, which shows the nearest grocery store from Orleans, which is the center of this group. 15 miles to Wichipec, a small grocery store there. The next closest large supermarket is 38 miles. So access to tribal foods that are natural and wild in the environment is really critical. So the last point that I want to make is that this sort of technology that's enabled and designed with community engagement is very similar to the concepts of patient-centered. So user-centered is really from the external perspective. I, as a technology developer, think about what you as a user need in order to use my product. I, as a provider or health system administrator, think about what you as the patient need to engage in the healthcare system. It's an external perspective. Empowerment is an internal perspective. What do I, as the user, what do I, as the individual, need from the system in order for me to do the best I can to improve my health or to improve my experience? So it really, to me, the use of participatory research, participatory design, where you're thinking about not just the users, but everyone in that cultural context, in that community, is how you get the best technology, the best health intervention design. And so that is sort of my upshot in terms of taking types and not turning them into stereotypes, which require one-size-fits-all technology. We can actually use social and mobile technologies to design experiences that fulfill individual users' needs, preferences, and values. And of course, lots of people to say thank you to, including USDA and all the folks in the Food Security Project, and then all the resources and citations that I've used today. Thank you.